So today we'll discuss about the ICU decongestion protocol. For example, a patient has come to you and the patient is volume overloaded. That patient can be a CKD patient, can be a heart failure patient. For some reason, he has developed acute pulmonary edema. Now, how to give the existing diuretics that we have? So that is the core focus of our discussion today. We have furosemide, we have metolazone, we have thiazide, we have estazolamide, we have spironolactone, we have all these things. But when to use, on what basis to use, everything we discuss today. So before going to the details, every decongestion has to have a goal. So in this case also, our goal is a negative fluid balance. But only a negative fluid balance won't do, because water always follows sodium, sodium always follows water. So we need to have also a negative sodium balance. This is very important. Sometimes we see the intake output, there is negative balance, we are so happy with it, but whether we have achieved negative sodium balance or not, because if the sodium remains high in the plasma, it will make you thirsty and you will drink more water. It will absorb water from the intercellular space. So overall the volume status of the body will remain same. So negative fluid balance or negative sodium balance is what is required. At the same time, the safety is, we are giving diuretics, but the goal has to ensure there is no AKI development, because all these drugs can intrinsically produce acute kidney injury. So we have to prevent that. That should be in our goal. Or severe electrolyte crash. Whenever there will be diuresis, there will be loss of electrolytes also. So that will also has to come in the goal of our discussion. So now let us say a patient has come to you with volume overload. Let's say for our discussion, patient has ADHF or acute pulmonary edema. So our first and foremost goal is, or drug to use is loop diuretic. We target the loop first. Commonly used Lasix or furosemide. Now how much to give? So let us draw a diagram here. So this is our loop. So we are giving Lasix. Lasix will work here in the loop and cause sodium and water loss, causing both sodium balance to be negative, water balance to be negative. So how to give this Lasix? Suppose a patient is Lasix naive or diuretic naive. In that patient, we need to give 20 to 40 milligram IV start. At the same time, on Lasix or on loop diuretic already on patient, you have to give 1.25 to 1.5 times of the dose, is IV equivalent. Now after you have done this, either this or this, at 2 hours we'll check for the urine output and sodium output in the urine. Right? If urine output is more than 100 to 150 ml per hour and sodium is more than 50 to 70 milliequivalent per liter in the urine, then we will continue same dose. Here also you can repeat the dose, because you know that this is working. At the same time, if this is not fulfilled, that means the loop diuretic that we're giving is not adequate. Here what we can do, we can repeat the dose again, but the important thing here is that you have to do must is early escalation, and this is called double nephron blockade or sequential nephron blockade. Right? So what to do here? We have to do it must. So here we have three options. Check the BMP. If the bicarbonate is increased, at the same time sodium also increased, or chloride is low, so here you must understand that it is the proximal convoluted tubule that is the culprit. So you have to add an agent that work on the PCT, and that is acetazolamide. Coming to our figure here, this is a loop area and on top of it lies the proximal convoluted tubule. This is the PCT. carbonic anhydrase inhibitor, acetazolamide. So we are giving the loop diuretic, it failed, we can repeat it, but at the same time, if the bicarbonate is high, sodium is high, you have to add an PCT blocker, that is CA inhibitor, acetazolamide. If the patient has low bicarbonate, at the same time sodium is high, so this means the problem lies in distal converter tubule. Here the drug that will give is Diuretics or metolazone. This is PO available. If patient cannot take PO, IV chlorothiazide is the drug of choice here. So here lies the DCT. Here you have given loop, it's not working, bicarbonate is low, patient is acidotic, you add here Diuretics or IV CTG, chlorothiazide, right? They work on the DCT. This is called, you can see sequential, this is number 1 nephron to be blocked, and this can be number 2 or this can be number 2. So this is called sequential nephron blockade or double nephron blockade, right? So how to know PCT versus DCT? So in both the cases we have given Lasix. So Lasix will work on the loop of Henle. So what will it do? It will excrete sodium and water via urine, right? Now what happens if it is being lost in the urine? What the PCT is supposed to do? PCT is supposed to do absorb bicarbonate, increase in serum, so absorb bicarbonate, and you know when bicarb is absorbed, sodium follows, sodium bicarbonate, and when sodium goes, water follows. So whatever your loop is supposed to do is doing, but it is being negated by the proximal convoluted tubule actions, enzymatic actions. So what will happen? The whole purpose is lost. So whenever there is a bicarbonate is increased, sodium is increased, you should know that the PCT is overworking. You block the PCT using CA inhibitor, that is acetazolamide. Another thing can happen in the DCT. What will happen? For example, sodium and water from loop, it will go to the distal converter tubule. So the distal converter tubule fluid will be rich in sodium and water. So what will happen? The DCT, which have a sodium rich content, now it will reabsorb the sodium. In this situation, the patient will be acidotic. The bicarb will be low, but sodium will be rising. And when the sodium will be rising in the DCT, DCT will absorb sodium into the system, into the plasma, and water will follow. So you see, the loop or the Lasix will work initially, but after some time, because the sodium load is increased in the DCT, the body will compensate by increasing the sodium reabsorption, so failing what Lasix is supposed to do. So here in this situation, you give metolazone, these are thiazides or chlorothiazide. So these are thiazides. Thiazides, this is acetazolamide, and we are giving furosemide, right? So here two things can happen. So either you give this or this, patient may start improving. So if improving, continue same treatment. If not improving, here you can do one thing, that is called triple nephron blockade. You give Lasix, you give Diuretics, you give acetazolamide, and here if this is also ineffective, this is called a refractory pulmonary edema, and here you have to do ultrafiltration. And in special circumstances like suppose ADHF patient or CLD patient, here we have another small target, that is the collecting duct. In these patients, or when potassium is required to be absorbed in the body, hypokalemia is there, here you can add aldosterone antagonist, that is spironolactone or epinephrine, right? Spironolactone. This is the number 3rd nephron or 4th nephron in the sequence, and this at Vor trial, this is chlorotic trial, and there is always a confusion about IV versus bolus. The dose trial has been done, which is there is no difference. So I choose IV infusion, continuous infusion over bolus in situation where I need a higher dosing, when a repeated bolus I have given and that is failing, and I need a constant natriuresis. Otherwise, there is no reason why you should use infusion over bolus. They are both same, except in these situations. So this is how the ICU decongestion protocol works, you first give the loop diuretic. The dose is different for naive and chronic users. If it is working, it's fine. You can reuse it. You can increase the dose. If it is not working, based on the BMP bicarbonate sodium level, you select whether PCT needs to be blocked or DCT needs to be blocked. Accordingly, you give acetazolamide or Diuretics or IV Thiazide. This is called double nephron blockade or sequential nephron blockade. So if one of them is not working, you can add both the drugs to the loop. That's called triple sequence blockade, right? Or patient is having CLD or ADHF, we can add spironolactone, aldosterone antagonist, which mainly work on the collecting duct and some part of the distal convoluted tubules, and it will work. If everything fails, then ultrafiltered is the option. Thank you very much.